uh, is a neuroanesthesiologist and a pain and palliative care physician. And she's a practitioner in New Delhi in various hospitals. And she's been awarded the Lifetime Achievement Award by the Delhi Neurological Association for contribution to neurosciences in February 2017. Her main interests are neuroanesthesia and pain and palliative care. And she has taken us through one of the important sessions in this program. And without much delay, I hand over to you, madam, to take us through today's session.
Thank you, Radha. And thank you, Shri Priya, for coordinating this session. And I'm once again back with you. And I'll just open my presentation, please. So without much ado, I'll just start off with the session. And in the previous session, we had talked about the WHO step 1 and step 2 with the focus on am I audible to everyone?
Yes, madam. Okay. Clear,
okay.
And your presentation is also clearly visible.
Thank you. So step 1 and 2, along with the neuropathic pain and the adjuvant drugs. And I suppose in the last session, the step 3 drugs would have also been discussed. But sometimes, even with the step 3 approach, this is a WHO ladder. And when you reach step 3, there is still a certain percentage who do not get satisfactory relief. It's a small percentage, around 10, 15 to 20%, but they may not even respond to strong opioids. So these are the patients who we say have difficult pain. And there are other terms for it, which are intractable pain, or refractory pain, or persistent pain, or opioid non-responsive pain. So what is the definition? It is pain related to cancer of at least 3 months duration that has not responded to standard treatment with opioids and co-analgesics. So that is a definition for refractory or difficult or intractable pain. Now, there are certain risk factors for intractable cancer pain. They include younger people are more prone to get it. Neuropathic pain may be more difficult to treat. Incident pain is also difficult to treat. When there's psychological distress, that can add to our problems. Patients who were previously on opioids or developed tolerance to opioids, those who have a history of addiction, and those with impaired cognition. These are the difficult to treat patients. Now, let me start with the case scenario. A 62-year-old man with CA rectum with peritoneal and liver metastasis on chemotherapy for 1 year. He developed acute intestinal obstruction somewhere after 1 year. Okay. And with pain in the abdomen due to probably progression of the primary lesion. Because the latest PET-CT was not very satisfactory. It showed progression of the lesion. Now, because he had acute intestinal obstruction, he was taken to the ER and he was admitted for conservative management. A Ryle's tube was inserted, a colostomy was done, and fluids were given, IV fluids were given. And then, when he had stabilized, he was discharged with the advice of continuing with palliative care, and they stopped the usual chemotherapy that he was getting. Initially, he had not much pain. He was going down physically. He was getting more and more debilitated, but he did not have pain. And he was taking the WHO step 1 and 2 ladders through the nasogastric tube, along with adjuvants for pain abdomen. But the abdominal pain persisted, and then he had to be started on step 3 drugs orally. He was started on morphine tablets. But one day he pulled out his Ryle's tube and he categorically said that he did not want it reinserted. There was a family discussion as to how to feed him because he had become extremely emaciated and weak, and how to give the drugs orally. Because with the Ryle's tube out, it was very difficult to give him anything orally. But because the patient had indicated that he does not want a rice to put back inside, we decided to respect the patient's wishes, that is the patient autonomy. And then we decided not to reinsert the rice. So he was started on IV fluids through his chemo port, but the pain grew worse, and then he had to be started on transdermal fentanyl patch, 25 mics per hour orally, with SOS, transmucosal fentanyl citrate, or OTFC, 200 mics SOS. This is the fentanyl lollipop. That is for the breakthrough pain. Despite all this, he had no relief. He was in agonizing pain and he was crying in pain. The family was extremely distressed. So what do we do next? Okay, so this is a prototype of a patient who's having difficult pain. So when you're facing this kind of a problem, there are certain steps that we need to follow. The first is we need to review the whole patient. Then we need to manage it based on the review, and that can be done either by pharmacological methods or non-pharmacological methods. Pharmacological includes all this. I will talk about this, and non-pharmacological are the non-drug therapies, which are also listed here, but we will go through that one by one. So the first step was, I said, review. So we can follow the A, B, C. In fact, there are 2 C's. The first A is the patient adhering to treatment? Then we have to believe the patient about the pain. Because Margot McAfee in 1968 said that pain is whatever the experiencing patient says is existing, whenever he or she says it does. In simple terms, pain is what the patient says hurts. The next C is a comprehensive pain assessment has to be done all over again. Look at the pain characteristics, look to the functional history of the patient. Is he able to walk around, do his daily activities, review the prior drug and non-drug history, examine the patient once again, and then review the patient. And the last C is correct the correctable factors. You may have to tap an effusion, or there could be ascites. In this particular patient, he was developing ascites again and again, and he needed to be tapped. Or is there an underlying infection that is aggravating the problem? Is there insomnia, anxiety? What about the nutritional status? So all those correctable factors need to be corrected. Now coming to adherence to treatment. Now for this, we need to review the analgesic regime that we had written, the prescription. We need to review the adjuvants, whether we need to add more. We need to check the patient's understanding of the dosing regime. What you have written, is it what exactly the patient is getting, or are they not giving it according to your prescription? So for that, we use what is called teach back techniques. That means you can ask the patient, or mostly the attendant, to tell you that, okay, are you giving paracetamol? How often are you giving it? What about morphine? What about the laxative? What about the sedative, etc.? One by one, you make them tell you back whether they are giving it according to your prescription. That is called teach back techniques. And that's how you know whether they're following the prescription that you have written to the detail. Now, there are some reasons for opioid ineffectiveness. I said that these people may be not responding to the strong opioids. So the most common reason for difficult to treat pain is accumulation of toxic metabolites of the opioids. It could also be due to the progression of the disease, which is very common. Or could there be a new pain type? Is there added bowel obstruction? Is there spasticity? Or is there a neuropathic element that has come? Or what about the intolerable side effects because of which you cannot escalate the dose of morphine? They are the neurotoxic side effects of opioids, strong opioids, which can manifest as sedation, delirium, hyperalgesia, or myoclonus. Or is the route that you're administering, is it not effective? Could there be poor oral absorption? For example, a patient with intestinal obstruction will not be able to absorb orally well. Or if there's a fentanyl patch put in, is there a diminished transdermal fentanyl absorption? Or if there is an IV or subcutaneous or spinal opioids, is there a malfunction of the pump, blocked needle, or a catheter malfunction, etc.? So all that needs to be looked to, whether your route of administration is effective or not. And of course, we need to look at the psychological, social, and spiritual factors also. So I talked about the pharmacological and the non-pharmacological methods. So let's discuss the pharmacological methods. So the first thing we need to do is opioid manipulation, because you're already giving an opioid. Do we need to convert the route of opioid administration, or do we need to switch the opioid, which is called opioid rotation? Or do we need to add an adjuvant? Like there are a whole lot of adjuvants that are given over here. Do we need to add them? Okay, these are the pharmacological options that we have. Now, first is route conversion. In route conversion, we are giving the same opioid, but through a different route of administration. For example, instead of oral morphine, we may have to switch to IV morphine. Or if you're giving transdermal fentanyl, you may have to switch over to the intravenous route. You're giving the same opioid, but you're just changing the route of administration. Now, it has been seen that high serum concentrations can be achieved by both IV and the subcutaneous route. In fact, both morphine and fentanyl can be given by both routes. Just remember the conversion factor. Oral to subcutaneous to IV is 3:2:1. That means if a patient is getting 30 milligram oral morphine, then the subcutaneous equivalent is 20 and the intravenous equivalent is 10. So that is how you have to keep the conversion factor in mind. Now, IV opioids, which is usually given when they're not responding to oral opioids, can be given as a continuous infusion for continuous pain, or you can give intermittent bolus if there is only incident pain. That if there is both incident and continuous pain, then we can use what is called a patient-controlled analgesia. So these are some examples of a PCA pumps. This is a disposable elastomeric pump in which the drug is filled in the balloon over here, and it is connected to the IV line, and there's a remote over here for giving the bolus doses. So these are disposable. You also have the CADD pump, which is a continuous ambulatory drug delivery system, in which the drug is loaded into a little container behind this, and this can be connected to the patient. Again, you have a remote by which the patient can access it, and if there is a breakthrough pain, he can just press the button and the bolus dose is delivered. Of course, in both these, there is a lockout period. In the lockout period, you can set the lockout period so that in that period, even if the patient presses the button, the drug will not be delivered. That is to avoid an opioid overdose. So these are the PCA pumps that are available for IV opioids or even subcutaneous opioids. So there is no evidence of the superiority of parenteral versus oral opioids to control intractable pain. Yet, the European Association of Palliative Care recommends the use of parenteral opioid infusions in cases where oral or transdermal opioids are failing to provide effective analgesia. So it is recommended when the oral or the transdermal route is not effective. Now we come to the other method of opioid changing the opioid is the opioid rotation. In opioid rotation, you're using the same opioid, you're using a same route, but a different opioid. For example, you're giving oral morphine, you can change it to oral methadone. So what are the indications? Intolerable side effects because of the oral administration of morphine, which can cause neurotoxicity, and or it could be poor analgesia despite the titration of morphine. Now, how does it work? This is because there is incomplete cross tolerance. Now, we all know that there is a tolerance between the opioids because they all act on the mu receptors. But there is a phenomenon called there's cross tolerance. That means if you're giving morphine, they can be tolerant even to pethidine or some other opioid. But because it's incomplete, that is why if you change the route, you can get better efficacy of the drug. So you can get greater than anticipated potency with another opioid because this cross tolerance is incomplete. So when you're converting from one opioid to another, remember 3 steps. I think this has been done in the previous class. I'll just go through it once again. First of all, you look up the equianalgesic table to find out the equianalgesic dose of that. For example, you're giving 60 milligram morphine, that is equivalent to 25 mics per hour of fentanyl. So when you once you calculate it, then you need to account for cross tolerance. So it is 50% for well-controlled pain, but for poorly controlled pain, then you reduce it by 25%. And the exception is methadone. And also remember to prescribe a rescue dose as well when you're giving the other opioid. Now, the opioid-induced neurotoxicity, that is why we cannot escalate the dose of opioids like morphine, is because it can manifest as sedation, delirium, myoclonus, hallucination, hyperalgesia, or seizures. And the cause of it is the accumulation of its toxic metabolites like morphine 3-gluconide and normeperidine. Now, methadone and fentanyl are the only other opioids of step 3 that we can change over in India. These are the only 2 strong opioids that are available other than morphine. Now, methadone is inexpensive and can be given orally. That is an advantage over fentanyl, but both are under the same legal control as morphine. So the use of methadone for difficult pain. Like I said, when you can give it as a step 3 drug, it is highly potent and it is effective for neuropathic pain as well because it acts on the NMDA receptor and serotonin norepinephrine reuptake inhibitor. I mentioned this in the previous thing about how the NMDA receptor antagonist can also be very effective for the neuropathic pain. It has no active metabolites unlike morphine. It has a long half-life. It is slowly eliminated, and so there is less risk of breakthrough pain. It does not accumulate in renal impairment, so it can be given when there is renal dysfunction, unlike morphine. Less tendency for tolerance and no cross tolerance, and it's relatively inexpensive. So these are the advantages of methadone. But it has some disadvantages. First is there's a high potential for accumulation and delayed toxicity. Then there's a risk of life-threatening ventricular arrhythmia if the QTC is prolonged, what is called the torsades de pontis. So we have to be very careful when we're giving methadone, especially in the ECG if there is a prolonged QT on the ECG. Now also titration is difficult, so the risk of overdose is there. And most important, it has to be given only by experienced palliative care specialists and not for the novice in palliative care. So the indications of methadone for difficult pain are, first of all, as opioid rotation, because of the ineffectiveness of the other opioid. Then its cost is quite inexpensive. And when there's true morphine allergy, then you have to give methadone. Or when there's neuropathic pain or renal destruction. These are the indications. But contraindications, QT prolongation, no reliable caregiver, and if there's a history of sudden unexplained death in the family, or there's a drug-drug interactions like for azithromycin, fluconazole, and amitriptyline, then we may not give methadone. So when you want to convert morphine to methadone, so this is a conversion table for that. If the morphine intake per day is less than 60 milligram, then you can give the dose of methadone of 2 to 7.5 mg per day. If the dose of morphine is between 60 to 199 milligram per day, then you have to divide it by 10, and that will give you the dose of methadone if the age is less than 65 years. But if the dose is more than 200 per day and the patient is older than 65, Then you divide it by 20. Now, methadone is available as 5 milligram tablet and syrup of 5 milligram per ml. So, as per expert consensus white paper, the equianalgesic doses suggested for methadone are very conservative, and we need not account for incomplete cross tolerance. That means you don't have to reduce the dose like you did for other strong opioids. The other strong opioid you can give for cancer pain is buprenorphine. It is another option for opioid rotation. It can give better pain relief, good tolerability. It can control neuropathic pain and breakthrough pain better. And it's given usually by the transdermal route. You have various strength of patches available, 2.5 mics per hour, 5 mics per hour, 10 mics per hour, and 20 mics per hour. One patch lasts for about 7 days. Sublingual tablets of 200 mics are available. The effect lasts for 6 hours and especially useful for breathing. Excuse me. I have a little sore throat, so I'm sorry for this. If you want to convert morphine to buprenorphine, then just remember, if the total morphine is less than 30 mg per day, we can initiate with a 5 mic per hour patch. If it is between 30 to 80 milligram, then you can initiate with 10 mics per hour. We can supplement with immediate release morphine or non-opioid analgesic for breakthrough pain. But if the patient is more than 80 mg per day of morphine, then even a 20 mic per hour patch may not suffice. So we have to think of other options. So what is breakthrough pain in cancer? That is one of the difficult to treat propositions in cancer. Now, breakthrough pain is intermittent episode of extreme pain which breaks through the opiate regime that the patient is on. So the patient is getting, say, 5 milligram morphine every 4 hours. But if the pain recurs in between, before even the 4 hours is gone, that is called a breakthrough pain. It can occur spontaneously or more commonly is induced by movement of the affected limb or bearing weight on the tumor-bearing bone or any other activity that the patient is doing. The incidence can be quite high, it can be 40 to 80%. And for this, we need to give a fast-acting, short-duration opioid. So the options that we have are, one is either you give the drug again, like if the patient is on 5 milligram 4 hourly and you get breakthrough pain at 2 hours, and you have to repeat that 5 milligram. Okay. If it is more than 1 hour, you can repeat the drug again. The other options are you can give fentanyl lollipops, like it's called OTFC. 200 mics and 400 mics lollipops are available. But you don't give it more than 4 units per day. It should be sucked over 15 minutes and not chewed. And the effect starts in 30 minutes and lasts for 2 to 3 hours. Sublingual buprenorphine is also available as a 200 mics mucosal patch that can be put inside the mouth. Buccal patch, it's called. So having talked about the thing, we need to also review the cause of pain. Is the pain nociceptive or neuropathic, or is there a need for an adjuvant drug? So I have already mentioned that this is where you get nociceptive pain and this is a neuropathic pain, or it could be a mixed pain. So this also needs to be reviewed. Now, ketamine is one of the drugs that can be used for difficult neuropathic pain because I told you the method of action. It blocks the NMDA receptor in the dorsal horn. And particularly responsive when the neuropathic pain is unresponsive to antidepressants and anticonvulsants. I'd mentioned all this in the previous class. I won't go through it. But I wanted to talk about burst ketamine. This is given for refractory pain. So you start off with 100 milligrams in 24 hours and give it for 3 days in a syringe pump. The patient has to be admitted in the daycare when you're doing this regime. If it is not effective, then you step up the dose to 300 milligram in 1 day and give it for 3 days. And if that is not effective, then you can go up to 500 milligram per 24 hours for 3 days. And if that is also not effective, we have to stop. This is called the burst ketamine or the pulse course of ketamine. So these are the various options that you have to treat intractable neuropathic pain. This I will not go through because I've discussed in the previous session. Again, local anesthetics can be used for difficult neuropathic pain, and particularly the severe intractable crescendo kind of pain. It can be given as an infusion or it can be given as topical local anesthetic patches. And the other drugs are topical capsaicin and topical gabapentin. So this ladder I had mentioned, the first line treatment, and the second and the third line are those for the difficult pains, like capsaicin, ketamine, cannabinoids, etc. So let's discuss cannabinoids in difficult cancer pain. Now, cannabinoids have been used for various ailments since ancient times. But in medicine, the use was restricted because of legal and social concerns due to drug misuse. But there are few symptoms can be resistant to current palliative care treatment options. And there is an absence of robust clinical data whether it really has a favorable risk-benefit ratio. So it is not routinely administered in palliative care treatment. Now, cannabinoids act on two kinds of receptors in the body. One is the CB1 and CB2 in the CNS. The CB1 is found in the brain, the spinal cord, and in the nerves. It is poorly expressed in the brainstem, and that is the reason for the low incidence of respiratory depression with cannabinoids. But it is the CB1 receptor that is accounting for the well-known psychotomimetic effects of cannabinoids. Now, CB2 receptors are mainly found in the immune system. They do not have any psychotomimetic effects, and they are being now investigated for its therapeutic effects. It has been found to have analgesic, anti-inflammatory, and even anti-neoplastic effect. The two phytocannabinoids that have been extensively studied are the THC or the tetrahydrocannabinol and the CBD, which is the cannabidiol. Now, nabiximol or Sativix is an oromucosal spray containing 1:1 combination of THC and CBD. Now, THC is the psychoactive part, and CBD is the one which has the anti-inflammatory properties. These oromucosal spray has been found to be well tolerated and provides improved analgesia and opioid unresponsive cancer patients. So the cannabis preparations that are available are the ones which had THC dominant. And remember, THC is the one that accounts for your psychotomimetic effect. So the ones available are dronabinol and nabilone. Okay, they are synthetic preparations. Then you have the ones that are CBD dominant. That is cannabidiol. And again, it is available as 99% pure oil that can be given orally. And then you have, of course, like I mentioned, that nabiximol, which is a 1:1 combination of THC and CBD. And it's available as an oromucosal spray. But remember that all these preparations, they have a high potential for abuse, and so they can only be given on a special prescription. So for cannabinoids for cancer pain, its analgesic effect is comparable to weak opioids. Now, weak opioid is like codeine. So 20 milligram of THC is got equianalgesic property to 120 milligram of codeine. Usually after 15 to 20 milligram of THC, the peak effect starts in 3 hours, lasts up to 6 hours. So you have to give it every 6 hours. So it can be used as a third or fourth line treatment for neuropathic pain when conventional therapies fail. It can also be used for chemotherapy-induced nausea vomiting. The drugs available for that are dronabinol and nabilone. They are both THC dominant ones. So I'll not talk about that because that is beyond the scope. Just remember the side effects of cannabinoids. They are, first of all, the neuropsychiatric that we all know that they can aggravate pre-existing anxiety, schizophrenia, and depression. They can cause impaired cognition, like excessive sedation and impaired motor skills. They can reduce the host response, so there could be an infection risk. And it has also got cardiovascular side effects, so you should avoid it in patients with heart disease. In palliative care, what are the indications? It's the third or the fourth line treatment for neuropathic pain. It can be used for the chemotherapy-induced nausea, vomiting. It can be used for cancer anorexia, and also improves the mood and antipsychotic effects. It also has anti-cancer activity. It can treat sleep disorders and seizures. And this was a recent study which showed that medicinal cannabis reduces pain and need for opioids among cancer patients. So it reduced the consumption of the opioid-based analgesics with minimal side effects. Okay. Now, is use of cannabinoids legal in India? What is the current status? Now, abroad, we know that it is being given, it is approved and given for treatment of neuropathic pain and multiple sclerosis and also refractory pain and cancer. In India, there was a petition in the Delhi High Court which challenged the provisions of the NDPS Act and said that it should be legalized for medicinal purposes. That was a petition. And the central government has informed the court this year, not this year, 2022, that use of cannabinoids is allowed in India for medicinal and scientific purposes, as per the law, and it is not completely banned. Okay. Now, I mentioned about corticosteroids. They can also be used for difficult pain in a wide indications, or number of cases. That is why it's called a multi-purpose adjuvant drug. Now, I won't talk about this because this I'd already discussed in my last class, the use of corticosteroids in cancer. Just remember that it can provide short-term relief of pain. So it's beneficial for those with less life expectancy. Then this is another drug, the GABA A receptor agonist like clonazepam and the GABA B receptor agonist can be used in refractory pains, okay? Particularly refractory neuropathy. Again, bone pain. Now, metastatic bone disease causes skeletal-related events, which includes bone pain. And this skeletal-related events are because of the bone instability and related to the treatment or due to the metastasis. So they result in localized pain at the site of spread and increased risk of fractures. The pain can be very agonizing, and it is one of the very important causes of refractory pain. So this is how we treat it. A variety of agents are available. The most commonly used ones are steroids, and bisphosphonates, and denosumab, and of course, palliative radiation. Now, malignant bowel obstruction. That can be another cause of refractory pain. So this can happen in terminal cancer, which is inoperable. So for this, octreotide is a synthetic hormone, which is a somatostatin analog. It acts by decreasing the splanchnic blood flow, decreases the portal blood flow, decreases GI motility and all the secretions, and also increases the water and electrolyte absorption. So octreotide is given in a dose of 300 mics in 24 hours as a continuous subcutaneous infusion for 6 days. Because the bolus is very painful, it's given as an infusion. And now this has been told that it's a drug of choice in malignant bowel obstruction. It can be combined with steroids and IUC. Having discussed the pharmacological options, let's move on to the non-pharmacological options. So I talked about this, that is a step 4 interventions that we can give for patients which are not responding to the step 3. So some of the interventions are the patient-controlled analgesia pumps, nerve blocks, epidural blocks, neurolytic procedures. They act by either chemical, thermal, or surgical. They cause the block the painful stimuli, either chemical neurolytic procedure, thermal by radioablation, or surgical. Or you can do intrathecal pain procedures like intrathecal pumps or spinal cord stimulation. Now, all these are considered in patients with severe side effects from drugs whose life expectancy is more than 3 months. So the various neurolytic or neuroablation procedures that are done are the celiac plexus blocks, superior hypogastric blocks, ganglion impart blocks, particularly for uh, pain due to rectal or perineal the region, or stellate ganglion blocks, or lumbar sympathetic plexus blocks, or intercostal blocks for intercostal neuralgia because of bone mets, or even trigeminal neurolysis. Now, there are also central neurodestructive procedures. So they are more in the spinal cord and in the brain. So they are, examples are rhizotomy, gangliotomy, chordotomy, pylotomy, tractotomy, and even operations on the limbic system like cingulotomy. Now, these are very rarely done. And it's only done when the life expectancy is less than 3 months. And they are associated with a lot of risk. So the risk-benefit ratio should be assessed. So it is, like I said, very, very rarely done these things. Now, having talked about the pharmacological thing, and we also talked about the non-pharmacological interventions, let's discuss some other non-pharmacological therapy. So some of them are dry needling, acupuncture, biofeedback, psychological therapy, physical modality, spiritual therapy, alternate therapies. So I've talked about dry needling. It's very useful to treat the muscle spasm and myofascial pains with cancer pain. And so how do they act? They cause reflex relaxation of muscles and improves the hypoxic local energy crisis because of the sustained contraction of the muscles. And it also releases the trapped inflammatory mediators. So physical therapy can be added on, and there are various therapies that are available like TENS and heat and cold and etc. So all this can be added on to your existing treatment. Now, a lot of cancer patients are having a lot of psychosocial issues. They include fear, anxiety, depression, anger, guilt. There could be financial issues, the fear of the future, concern about the loved ones, loss of role or role reversal, and even questioning God. So the various therapies that can be given include counseling, communication, sometimes medications. Then there could be support groups, and providing financial support is also one of the therapies for this. So coming back to our case scenario, let us review the cause of intractable pain in this particular gentleman. First of all, we need to know what are the medical reasons? Was there a progression of disease? So in this particular gentleman, the colostomy site definitely looked unhealthy. The second is, there was a failed route of absorption. There was not only poor oral absorption of opioid, but there was a decreased transdermal fentanyl absorption. So these were the medical reasons that could be causing the refractory pain. But were there other psychosocial concerns that also need to be looked into? Anyway, what was done? He was readmitted to the hospital. The colostomy was found to be non-functional, and it was obviously the cause of severe pain. And also the disease had progressed. Then a opioid route conversion was done. So instead of the transdermal fentanyl patch, he was started on fentanyl infusion with supportive care. The pain gradually subsided. End-of-life care was instituted, and this was explained to his relatives, and he expired free of pain weeks later. So, were we too drug-centered or intervention-centered in our approach? Did we look at the role of the non-pharmacological interventions in this particular gentleman? Now, what were the psychosocial concerns in this patient? He was a highly educated retired doctor. He had no financial concerns because the cost of the treatment was fully reimbursed. He had a supportive family, a devoted wife and daughter. The wife was the main caregiver and had taken the role of the head of the family, managing all the medical appointments, the financial part, everything she was taking care of. But he did have psychosocial concerns. He was depressed because, being educated, he knew that there was no cure and he would not live long. So he had a sense of hopelessness, helplessness, and powerlessness. Being highly educated, Yet he felt totally helpless and powerless. He had other psychosocial issues. Because of the COVID also, which happened during that time, he was experiencing loneliness and isolation because they had withdrawn from friends and relatives for 2 years. He had a low self-esteem. He was totally dependent on his wife, even for his self-care activities. Guilt. His family had given up all their activities. His wife had given up her job so that she could be his full-time caregiver. And there was a role reversal. The role that he was as head of the family was now taken over by his wife because he could not do it. So there was a role reversal, and that also must have hurt him a lot. So all those concerns were there in this particular patient. So once again, to recapitulate, we have to go through the step ladder, that is step 1, step 2, step 3. If that does not work, then we need to go in for the other options like interventions. But at the same time, we need to, at every step of the ladder, we need to look at the psychosocial aspects. And if everything fails, then we need to consider palliative sedation. You can accept failure, but we should still not desert the patient. We should be there till the end in this difficult journey of theirs. We can be frank about the failure of our treatment, but we have to convey it with sensitivity. And we have to continue with the psychosocial spiritual support and treat any worsening of the condition. Thank you. Thank you for your patient listening.
Thank you, madam. Yes, it is. See, we do face these situations. So, madam has taken us through well how to manage and get to a stage where we can to do what is possible and then move from there. So many options have been suggested. So, we need to be aware of all these things that are possible and things like that. And always you have to see, isn't it, what is feasible, not some cost, availability, everything has to be considered. All of you have to be aware of all these options. And always we say you have to tailor make it to your need. What is available in your area? So where you are, and use it accordingly. Not that only one option. There are many, many ways and routes to achieve something. And one more thing I just thought of adding, madam, like as you said, all these alternative methods and things, they say even like good breathing and improving the oxygen, because I, having done chronic pain, I used to tell and teach. There's also scientific evidence for that.
Yes.
It improves the oxygen stores, and micro level oxygen is what is needed at the mitochondria. So they say two things it does. It improves the oxygen levels, and also another thing is that antioxidant. So these are the two things set for simple improving your oxygen stores. And that you can teach. I know when someone is in terminal illness and things, it may not be possible, but when they are not in that state, but when they are in a state finding it difficult to cope with their pain, that also can be helpful. That's the only thing I just wanted to add, madam. And then let me check in the chat box if anything else additional, not at present. And as you all did before, no, you can type or unmute and ask. See, this difficult pain is something is practically anyone and everyone can face. See, always it's not going to be easy. That's the beauty in our profession also, no? That's the
Yes,
challenge. That's the challenge to face. And it does come up. It will not be easy all the time. Any burning questions, or should we go for the case discussion and come back? Someone, how does music therapy help? You go ahead, madam.
Music therapy. See, music is supposed to be things like music and art, they may be releasing some good neurochemicals in the brain.
Endorphins.
I think so, endorphins.
Yes.
And also
See,
serotonin and all those things, like laughter.
Correct.
Laughter, exercise, all increase serotonin levels, you see. So it is like something like an SNRI drug that you're giving. So I believe that, happiness, yes.
Happiness. It is easily said that all these are the same, isn't it? So many alternative things are there. Recently, I've even attended a program which was done in Chennai to say it was from people from different parts of the world itself were there to show how music therapy is helpful for malignancy patients.
Yeah.
So
and
these are all
even art therapy, drawing and things like that.
Yes, handwork.
Doing beautiful drawings. I've seen in our cancer center that they were all sitting in one place and making drawings. Why do they do that? That is a type of a thing to, maybe the mind gets distracted from the body, and also it maybe, I think it's all, we don't know about the brain, how it works, but these things all do help.
Multifactorial, and then like all many other things. No, see, it will make them happy. It's changing their focus. So many things are there in that. So
and
all
of course,
these,
I think they also act by the gate control therapy.
Yes,
like
yes,
they will, all these good things will actually close the gate so that the pain impulses don't go so much to the brain.
Yes, many things.
Dance therapy also people are doing now,
Yes, that's what. In the one which I'm telling, which happened in Chennai, it had music. So they had all, there was dance also. Music, dance, everything was incorporated in that. And multifactorial, multi-pronged, I would say. Focus, happiness, so many things are done by that. And then that is what is the beneficial thing which brings people together. They will open up themselves. They will meet more people. There are multi things. You can keep on talking on that.
Ma'am,
go ahead.
Can I ask a question? Ma'am, as in our allopathic practice, in the very difficult pain control scenario, is there any role for Ayurvedic and homeopathic therapy in this difficult pain management?
I believe there is a role of alternate therapy also. Okay, like applying oils and massage and all can help in addition to what you're giving. Not as a standalone therapy, but in over and above what you're giving. It will help. Like the massaging and putting all these oils, they do have some beneficial effects also. But like I said, not a standalone.
Yes, ma'am. But will it be ethical from our side to prescribe for those alternative therapy?
We don't have to prescribe it, but we can tell them to do it.
Do it, okay.
Or really tell them to do it. Yeah. We cannot advise Ayurvedic therapy. That we don't write. But we tell them that you must try that also, Yeah.
Okay.
So there are some questions. Buprenorphine patches 5 mics per hour lasts for 7 days. Do we change the patch every hour? No, only at the end of 7 days you have to change. Okay, it lasts for 7 days, no? So only on the 7th day you have to change it. Is that clear? And the second question, are these cannabis preparations available in India? Yeah. You have to go to the right person. They are prescribing it and they are giving it also. It's no longer underhand now. Because I have seen a patient taking cannabis and they showed me the prescription of the doctor. So it is available, but you have to find the source from where you have to get it.
Regarding that Ayurvedic and Homeo, what I was trying to say was, see, we are not legally or officially entitled to do that, isn't it? Because we are not registered practitioners for that. So what we say, because I don't know about it, if they want to do something, they can do it along with this. That is what we have always said. That is the thing, because I was not sure if Dr. Gyan, are you yourself trained for that? Because Dr. Gyan was asking, are you also trained in other chemical medicines?
No, ma'am.
Okay. The questions in the chat have been answered, I think, right? Both. We need a multidisciplinary teamwork. Okay, and one more, yes, that is, and now one more question. What can we do if the non-opioids fail?
What is the meaning of that? Non-opioid?
I too didn't catch the question. Can that person explain? Let me see.
That is, even if the other than opioids and all, like cannabis and all, you know, if those fail, what to do?
You have to go back, recheck everything. See, always go back, analyze, see what is, see step by step, first opioids, then opioid rotation, and then like you go in a methodical order. If not, go back to step one and then review, see what are the things. The disease might have progressed. See, 1 week, 10 days and all is, even though it may seem as 1 week, 10 days is long time in those diseases and the stage of the disease. So you have to go back, reassess, review, check everything, what has changed. Physical, psychological, what is that has changed in that patient at that point of time, and then go back. See, sometimes this first one will work again.
Are there any chances that everything may fail?
Yeah, there are chances of that also.
Yes.
But we should support the patient.
Yes.
Yeah, exactly.
We have to support them, show them compassion and be with them. Don't desert the patient. And then we may even think of palliative sedation if required, if the patient is in a terminal condition. Okay.
Okay, thank you, ma'am.
So that's what. So that is the disease of the patient may be there, and then always being there for them.
Yeah. Okay. Thank you.
Okay. And as we said, this alternative methods also, you can try and see. As Madam said, no, doing complete alternative, I don't know how helpful it may be. But if you have that and this together, sometimes it may be. Many people do that in many pain places where they teach and do that. They do both also in some places. And TENS machine and all do work very well when they are on medication also. So you ask them to use the medication and use the TENS also for additional pain where they have. It won't be in one place. It will always be in multiple places. So those type of things can be done. Oh, is there something else in the chat? How to choose between fentanyl, buprenorphine patch, explain palliative, and also explain palliative sedation.
See, fentanyl patch may be my preferred choice first, because first it lasts only for 72 hours, whereas buprenorphine is for 7 days. And it is, I think the effect also will wear off faster once it is stopped. So fentanyl would be my preferred choice. Exactly why, I cannot tell, but I've used fentanyl more often than. And sedation, palliative sedation. Okay. Is there a class on this palliative sedation and all later on? Will it be covered?
There is an end-of-life session, madam. End-of-life care session is there.
I think that will be dealt in that class.
That's what. So,
only mention about palliative sedation is.
What is that, Sripriya? Didn't catch
we don't cover it on an extensive basis, but just as part of the ULC only.
Radha, would you like to take that question?
See, that's what. See, basically, palliative sedation, I would wait now. And when we come to the end of life session, if it is, basically it all depends on whether it is done in hospital, whether it is done in home. So there are so many ways, and it can be done in both places. So it may be now it is too early for that when we get to that stage, because another mode of subcutaneous infusion, what it is, all that also has to be covered in that for you to know. So I would just leave it for the time being. And in that end of life care session, whatever is dealt, and then if not, we'll try to cover it in that and explain. Is that okay for whoever had asked? Let me check that. Who was the person who had asked it? Ratan Singh, I think. How to, isn't it? Explain about palliative. Dr. Ratan, is my explanation for this okay, or what is your response to it? Thank you. Thank you then. So we will try to cover, because it has to be explained in both ways. How, where, when, and how is it given. Okay, Sripriya, in that case, shall we go on to the case discussion, please?
Dr. Sushma?
Good evening, everyone. I hope I'm audible.
Yes.
Okay. I'm Dr. Sushma. I'm a pediatrician working as assistant professor in MVJ Medical College, Bangalore. We recently had a child of 7-year-old with a case of pre-B-ALL with early CNS relapse. He was diagnosed with pre-B-ALL at the age of 4 years. He was now 7-year-old. And he was diagnosed with early CNS relapse in his 20th chemotherapy session. He came with complaints of oral ulcers and painful swallowing since 2 weeks, and he also had severe backache. He was started on R3 protocol chemotherapy. During his 20th cycle of chemotherapy, he was found to have CNS relapse and spinal relapse as well. Child had also developed oral ulcers since 2 weeks, which were painful. He was unable to eat solid or liquid diet. He has stopped speaking due to painful oral ulcers. His pain score was 7 on 10. He also had backache, which is upper and lower backache, and was severe. He could not describe the nature or radiation of pain, but his sleep was undisturbed. Yes. On examination, he has multiple shallow oral ulcers with grayish base. They are located on tongue, palate, gums, and buccal mucosa and lips. Oral thrush was seen, and there was bony tenderness in the thoracic and lumbar vertebrae as well. In view of neutropenia, blood cultures were sent, and he was started on IV fluconazole for oral candidiasis. In view of severe pain in the oral mucosa, topical application of lignocaine was started, and multivitamin supplements were given. IV paracetamol was given for pain control. The psychosocial aspects were, he was being cared by a single parent, the mother. Father had died in an accident when he was very young. Mother is working as a tailor and has studied till 12th, and she is confident in looking after the child. Elder brother is studying in college and is actively involved in taking care of his brother. But the child's mood seemed depressed throughout the course in hospital. The medications that were given were IV paracetamol, antibiotics, antifungals, metronomic drugs, including oral dexamethasone and mercaptopurine. The main concerns were the child refused to articulate the nature, severity of pain, or the response to pain medication. Child's mood was low during the hospital course, which we could not differentiate whether it was because of pain or because of depression as such. To summarize, our child was diagnosed with pre-B-ALL with early CNS and spinal relapse, oral candidiasis, and aphthous ulcers. He was treated for oral thrush, which showed partial improvement, and metronomic drugs were continued, but the pain assessment was difficult and medication could not be titrated. I want the discussion for difficulty in pain assessment in children as such, and how to differentiate the pain and depression, and titration of pain medication in children. Thank you.
Thank you, Dr. Sushma. Madam, what exactly, what is the extra, other than yourself, do you have any other psychologist or anyone in your hospital to help you with assessing children?
We do have a child psychologist, ma'am.
Okay. Okay, then let Madam take over, and then I will come back to you, dear.
In children, like in a 7-year-old, I don't think the visual analog scale of the NRS is well suited, because they will not be able to tell the score in a proper way. It's the Wong and Baker facie scale that is more important, I think, for assessing pain in children. So by just seeing the facial expression, we try to gauge the level of pain. That is one. The second thing is that obviously the child is depressed, because I don't know whether the child is interacting with anybody at all. It's only the mother and the brother. Are they, in the pediatric wards and all, they may be. Can we go to the gallery mode, please, so that we can see everybody?
Yes, I was also, thank you, madam. We can come out of the presentation, Sri Priya.
Okay. So is a child in the environment, is it a depressing environment? Are there people around, or the child is alone in a room? Can you tell something, whether what are you doing to make the environment a little more bright, Sushma?
Yes, ma'am. Child was refusing to talk to the mother also. Child was very angry because he was in hospital, and he refused to interact with any of us even after multiple attempts. And he seemed, but his elder brother seemed very caring, and he was interacting with his elder brother, but in a sign language, because he could not speak because of the painful ulcers. At home, there is not much of a depressive environment, but in hospital, he was very angry that he was in hospital, and he was depressed.
Okay. So what kind of antidepressants can you give children, since you're a pediatrician? Do you think you need to give medications also for this child? Is antidepressants given for children?
Yes, it can be given to children based on
like in this patient, if he gets something like a antidepressant, that will take care of the neuropathic pain, because this can also cause a lot of neuropathic pain as well, because of all the nerve endings. So if you give drugs like tryptomer, do you give tryptomer in children? Amitriptyline?
We have not. I'm not an expert, as in I don't have experience with it.
Okay, sorry, can I speak up?
Yeah.
Ma'am, tryptomer is not the first drug of choice, ma'am. As of now, according to the guidelines, the only drug that is tested and safe in children is escitalopram, and that too in low doses because it's 7 years of age. Escitalopram.
Escitalopram. Okay.
Literature is short for escitalopram as far as neuropathic pain is concerned.
No, it is not very effective for the neuropathic pain. It will be
not
more for the
effective.
Anxiety and depression of the child.
Yes.
Okay.
So, and before even, I understand tryptomer can be maybe an option, but before that, if you're even considering antidepressants, the child should undergo formal assessment, because if it does come under the adjustment purview, like what ma'am is saying, is that the child is angry because he's in the hospital, but is a little well adjusted and better at home. So, formal assessment for depression should first happen.
See, we are not treating the depression for depression point of view, but an antidepressant which has adjuvant properties, because it will take care of the neuropathic pain. Because for depression, you give much higher doses. For neuropathic pain, you give lower doses.
Yes.
So either you give an anticonvulsant or an antidepressant, because you have to treat the pain along with your local agents that you're using. You also need to treat the neuropathic pain that the child is having. See, you can't expect the child with pain to be happy, particularly when there are mouth ulcers. So you need to treat the pain before, and maybe keep the child at home, and to the child to be a little happier than what it is right now. A child with pain can never be happy, right? So first is to treat the pain. And the pain is obviously there is a lot of neuropathic component. So what are the painkillers that you're giving this child, Sushma?
Oh, IV paracetamol, and we switched on to oral paracetamol.
Oral paracetamol. Okay. So, so we can give that along with either an anticonvulsant, antidepressant, because to take care of the neuropathic pain part of it. And also, even there are some NSAIDs lozenges that are available, no? Fluribrufen. Have you heard about it? They are lozenges that can be sucked and can provide some kind. It's an NSAIDs basically, NSAID local. That can be like you have that eye drops also. So like that, lozenges are also available that can be put in the mouth for relieving that pain. In addition to what you have already said, you're giving, what did you say, Claude, for the mouth? What are you
Just
giving?
some local anesthetic. It was,
That was-
that's what was then.
Topically.
Okay, topical. So there are many topical agents that can be given. Shall I just, if you don't mind, can I show one presentation? Then I will show you the agents that can be given topically.
Yes, madam. And then about few things were the child can be assessed fully by the psychologist. And then if the pain, because we really don't know, the pain may be still higher, it may not be. And there are situations the child is on chemo and things, no? So even morphine can be used. If the pain is very high, you without assessment, you're telling it is mild, not to offend you at all. Okay, don't ever think like that, because from your statement only I am telling. I am not making any decision or judging anything here.
Yeah.
Okay.
So our first thing is to treat the physical pain, and then the psychological aspects have to be dealt with.
So
like we cannot have a happy child who's paining, who's having a lot of pain. That child can never be happy. Okay.
Because I have seen children with, like, I've seen a child like an 8 or 9 year old with bone malignancy and was so much in agony. And then we just started very low dose morphine. And in third day when I saw him, he was a different child. So the pain has to be first. I know it is not easy, and there are few clues. Like you can ask the mother or who is with the child always. They will know clear difference to child being pain-free and child being in pain. Eating habits, their general habits, general activities, everything will be affected. See, you're all pediatrician, you will know more. But these are things. So as you said, assessment is not easy, but we have to make all steps and measures to do the assessment properly.
Yeah, and if the assessment is severe pain, then like Dr. Radha said, please give the strong opioids only for this child.
And you will, it will help. It will, all dose titrated. Okay, so we are going to give only body weight per kg body weight, and it does work very well.
Thank you, ma'am.
So
those things are essential. Madam, you go ahead and show the presentation.
I'll just show you, just to say what are the things that can be given. 1 minute.
One more thing, Dr. Shushma, in the meanwhile, when Madam, is there any palliative care facility near you who have morphine? You are from Bangalore, right?
Yes, ma'am. It's
St. John's is there. It's not.
Yes.
St. John's has a full-fledged palliative care department. So that's all. So those type of things, no, either first to know availability for children, even liquid preparations. Liquid preparations are available in some centers. So those options are there to look into. because better pain relief, there may be a pediatrician who may be able to help you and guide you accordingly in that.
Can you see the presentation?
Yes, madam.
Okay, 1 minute. So these are some of the things that I have found. Okay, one is this 10% lidocaine spray can be used for the mucositis. Then, like I said, some NSAIDs can be given, like benzodiazepine, that is cool benz oral rinse. It can be even 15 ml every 3 hours. You gargle it for 20 to 30 seconds before spitting it out. Then this I said is flurbiprofen lozenges. So these are some of the NSAIDs that can be given. And then you can also give some antihistamines like doxepin hydrochloride as an oral rinse. And then opioids can also be given in very severe cases. Morphine oral solution, 2 milligram per ml, if you can make that strength, and then ask them to hold it in the mouth for 2 minutes and spit it out. You can do that every 3 to 4 hours, or even cocaine. I don't know if that is available. Morphine can definitely be available. Then you have mucosal protectors. Okay, so they are gel clear, which is polyvinyl pyrrolidine. You have to mix the contents in 40 ml of water, rinse the mouth, and then spit it out. And do that before food so that the food will not irritate the ulcers. So these are some of the mucosal protectors that you use. And of course, there's a magic mouthwash also, which is a combination of lidocaine, viscous 2% with antacids and antihistamine. So these can also be given. And topical steroids can also be applied for aphthous ulcers, like 0.1% triamcinolone or hydrocortisone leukoadhesive pellets and betamethasone. So these are some of the options. So I thought I will just tell you because I had it with me. I thought I will share it.
Okay. Thank you very much,
Yeah,
madam.
thank you.
These aphthous ulcers, I have used them. Okay, for aphthous ulcers, I've used, but in between they were not available, madam. Are they available again freely?
Which one?
For aphthous ulcers, like last resort, I used to ask patients to even powder there used to be the Decadon tablet, and like that was because sometimes these paste and things are not available easily.
So these are all available. I
Okay.
checked up in the net also, like
Thank you,
gel
thank you,
clear
madam.
and
That's
cool
something
vents,
useful.
they're all available. So these are some
They
of the
are very
options.
useful.
Even if not anything, even morphine, if it's that severe pain. But before that, it's very important to treat the pain of the patient, counseling the child, maybe with some activities and things like that. And if the child is happy at home, keep the child at home only. That will be a better option. And encourage the mother to keep the environment of the child happy rather than a very sad and depressed environment we should avoid. Maybe
And
have
one
some
more-
children come over and play games or things like that,
No, when the child is at home, maybe a better assessment also can be done. See, maybe he's not revealing, naturally, like even adults can be apprehensive when they are in hospital and things like that. So a better, even for you, if the child is at home and then you're able to find out your assessment of the pain itself may be better off. He may tell, I am in severe pain when he's at home. So something like that might throw more light for our own assessment also.
Yes.
And a psychologist, like you said, there is a psychologist over there who may be able to get to be with the child and mother together. And with her, you can see the child. Let her have a consultation. And then after that, if you see, sometimes it will be a totally 360-degree change.
Yes. Some games that the child likes, the indoor games they can play and things like that, all that. I'm sure you must be taking care of it, but...
Yes, you are a pediatrician. We need not teach you anything.
Yes.
Thank you so much, ma'am.
Any other questions?
Okay, I'll check the chat box, madam. Is there anything else? So the main three things in her discussion were assessment of pain, treating the pain, were her things, right? Anything else, Shushma, you can add on from what I...
The titration of pain medication, assessing the response in children.
See that one, like an adult, you have to just start with low dose. See, from what I have done, I would say we started off even for that child, and you can ask them to see them, not like wait for 1 week or things. I saw the child every 2 days until I got the pain under control. Madam, is that okay or anything else to be added?
I think that's fine. The NRS was not the best scale for this child, because a child cannot explain out of 0 to 10 how much your pain is. And then if the child is really having that severe pain, then we have to give the appropriate drug according to the WHO analgesic ladder, and an adjuvant if necessary, and not to forget the topical agents that we are using, which a whole lot of them are available in the market. And then, of course, look at the psychosocial aspects, like a total pain management. Keep the child in the child's environment that the child likes, with a lot of childlike activities around him and things like that. I think that's important.
Okay.
See, that's what's not a straightforward case is what, no, that as Madam took us through this, the case presentation through her main presentation. So similarly, only when you don't have something straightforward is what you use all other alternatives. And especially with children, it's not simple and straightforward.
Exactly.
So there, if need be, get assistance in whatever forms are needed, and then assess it properly and then move forward. And then in that also you have a methodical approach in doing that.
And definitely there's a role of child psychologist in this.
See, because a single mother, already there are some issues in the family. Okay, yeah. Some financial issues may also be there. How much is revealed? Many times, all of us have pride. Nothing is said straight away. So that is also very natural. So there will be hidden underlying things, so which will take time. We also have to take time to sit and talk with them and get the input. Maybe, as you said, with the brother, he is more comfortable. With the brother, if you get to talk and see, the psychologist talks and speaks and then might help. And once you make the child pain-free, children will respond, and then even he may start doing things like that in a better way. Anything else anybody wants to ask or add on? Overall, not only with this case, with the total topic today, please either unmute, and you can all can unmute and ask, or type, either way, fine. If not, I will hand over to you, Sri Priya.
Thank you, ma'am. Thank you, Dr. Mary Abraham. We could really make out your thoughts, condition when you're talking in between. I was really, so sad to see that ma'am has been coughing in between, and still you were so enthusiastic and passionate to walk us through the session as scheduled, ma'am. Thank you so much for that. That itself shows your passion and dedication, and we do look forward to having more sessions with you in future. And thank you, everyone. Thank you everyone for joining in and making the session wonderful. And thank you, Dr. Sushma, because pain itself is difficult, and when it comes to the pediatric group, it becomes more difficult, because being parents, we all realize that, especially a 7-year-old who is just at the verge of understanding things, and if he himself decides not to disclose, then we are done for. Even in infant's case, we can like make out, because as the saying goes, infants can't hide feelings. If they are painful, they are in pain. If they are playing, then they are not in pain. But when it comes to 7-year-old, it is really hard. So thank you, Dr. Sushma, for bringing in that case, and thank you everyone for joining in. So with a promise that we will meet again in the next session with another interesting topic and yet another eminent faculty. This is Sri Priya, along with Dr. Mary Abraham and Dr. Radha Venkateshan, signing off from the Tips Echo Hub. See you in the next session. Till then, everyone take care. Bye-bye.
Thank you. Thank you,
Thank
Radha.
you.
Thank you, Radha, for
Thank you, madam. Thank you very much.
Thank you so much.
Take care.
ma'am.